Hello, everyone. I'm Dr. Arman Danielyan. I'm a child adolescent psychiatrist practicing in San Francisco Bay Area. And today we're going to be talking about attention deficit hyperactivity disorder in children, adolescents, and adults. But before I start with the actual presentation, there are some disclosures. This is the disclosures from the Armenian American Medical Society. And all the slides are going to be available to you, so you can also go deeper into the details later on. And this is my brief bio sketch. Again, I'm not going to spend time on this. You can review this later if you're interested. So the title of today's presentation is Beyond the Diagnosis, Understanding ADHD Across the Lifespan. And again, ADHD stands for Attention Deficit Hyperactivity Disorder. So I have no conflicts of interest or disclosures to make here. So what are the learning objectives? The learning objectives are to describe the core features and developmental trajectory of attention deficit hyperactivity disorder across childhood, adolescence, and adulthood, to recognize the challenges and barriers contributing to underdiagnosis and undertreatment of ADHD in youth and adults, to differentiate ADHD from common comorbid or overlapping conditions like anxiety, depression, autism spectrum disorders, other neurodevelopmental and learning disorders, and to apply evidence-based strategies for the assessment and treatment of ADHD. Some brief kind of key facts about ADHD I wanted to share with you. So as you can imagine, ADHD has been there like forever, I guess, since human beings existed. But it has been clinically described by a German physician in 1775, and in 1937, Charles Bradley described improvement in symptoms of ADHD-like behaviors with amphetamine medications. And in 1960s, the United States Food and Drug Administration, FDA, approved methylphenidate, brand name Ritalin, for behavioral disorders in kids. Now, since this is Armenian American Medical Society, sometimes I'm going to kind of travel across the ocean and talk about the situation in Armenia as well, because I think it's important. And unfortunately, I think the issues with diagnosis and treatment of ADHD are not well established yet in Armenia. And so, as I mentioned, the FDA approved methylphenidate in the 60s, and almost 65 years later, we still don't have psychostimulant medications available in Armenia. And I'll show you later on in this presentation that psychostimulants are the most effective or efficacious treatment option for symptoms of ADHD. And although you would probably hear from many, people, even physicians, overseas, stating that ADHD is a kind of an American diagnosis. If you look at the actual epidemiological studies, the prevalence of ADHD is not drastically different across the world. So as I mentioned, it is a very biological condition, right? And if you look at the neuroimaging and genetic studies, you'll see that it is a very strongly biological condition. And I always tell my parents, my patients' parents, who often come to me and say, well, I think my kid has some ADHD symptoms. I think, it's nothing serious, but I want to get some help to maybe improve his or her academic performance. And I don't want to scare them, of course, but I always do kind of provide some information about ADHD, that it is a true, the psychiatric condition, and you have to take it seriously because, as I will show you later on, if you don't address symptoms of ADHD, if you don't treat this condition, it might lead to significant, difficulties and has pretty high rate of morbidity and mortality if untreated. Studies of twin and adopted children indicate a high heritability of ADHD, close to 90%, and there are some prenatal and postnatal factors like maternal smoking and alcohol use, low birth weight, premature birth, exposure to environmental toxins, etc. So now let's talk about the epidemiology of ADHD. And again, the numbers, change all the time, but in general, it's believed that about 6 to 8% of the children and about 4% of adults have this diagnosis. Now, in psychiatry, we use this classification called DSM, Diagnostical and Statistical Manual of Mental Disorders, and we now use the fifth edition. And the difference between the fourth and the fifth edition in regards to the diagnosis of ADHD is that in the fourth edition, in order for you to diagnose somebody with ADHD, you should have been able to prove that the symptoms have been present there before the age of 7. Now, even if you diagnose the condition at, let's say, the age of 15, 20, or even as an adult, you should have some kind of evidence, some kind of proof that the child had symptoms before the age of 7, although he or she never got diagnosed with it. And now with DSM-5, they changed the age of onset criteria to 12 years, right? And as a result of that, there was significant jump in the prevalence rate now because you have more time to diagnose ADHD, right? So according to some data, the prevalence is about 10%. And according to a most recent national survey of parents, about 11% of children in the United States aged 3 to 17 years have been diagnosed with ADHD. And ADHD is considered to be a chronic condition. It persists into adulthood, so you don't really get rid of ADHD once you become an adult. The prevalence of ADHD is higher in special populations, right? In homeless children, adolescents, the prevalence rates have been established to be close to 22, 23%, and in prisons it's close to 20%. Now let's travel back again to Armenia and see what's going on with the diagnosis of ADHD there. And as you can see, I personally couldn't find any solid studies or data coming from Armenia about the prevalence of ADHD. According to World Population Review, the prevalence of ADHD in Armenia is 1.16%, which obviously is most probably very inaccurate. But there is another study which was done in that geographical area, Middle East and North Africa, and it's a meta-analytical study covering 63 studies, close to 150 subjects. The prevalence is about 10% in that area, which is kind of close to what I think we just discussed about the United States, right? And interestingly, there have been at least, it looks like, 19 studies done in Iran, which showed that the prevalence there is about 22%, which is clearly a bit higher than elsewhere in the world. But again, I don't know specifics of these studies done in Iran. Now, as you can see, the prevalence of ADHD has been going up since 2000 until 2022. And I think one of the important variables here to consider is the COVID pandemic, right? Because before COVID, many kids and adolescents who, let's say, live in rural areas, they didn't really have an opportunity to see a child or adolescent psychiatrist or even, developmental pediatrician. And many of those kids who had the diagnosis never had a chance to get diagnosed and receive treatment. Now with the pandemic, if you remember, there was a significant a jump in use of telehealth or telepsychiatric services. And as a result, we have been able to get access to those families in rural areas. And as a result of that, there was an increase in the diagnosis of ADHD. Now, the prevalence by sex, as you can see, it's clearly significantly more prevalent in boys than girls. As you can see, starting from the age of 3, 4, 5, the rates go up, and it kind of plateaus around the age of maybe 10 or 11. And as you can see here, again, the prevalence rates of ADHD go up significantly throughout this past, 10, 20 years. And the curve is significantly different for boys than girls. I mean, the diagnosis of ADHD in males has been significantly more frequent than in females. Now, for race and ethnicity, as you can see in this slide, the most common ethnic group is whites when we have the diagnosis, followed by Black and Hispanic population, and significantly lower prevalence in Asian population. But I think it's also important to understand here that there have been established, studies showing that, many, Black and Hispanic kids don't have the same access to care as, let's say, a white population. And so the prevalence in those specific ethnic groups might be impacted by that particular variable. So again, this is also about the prevalence data in kids 5 to 17-year-old. And as you can see, again, it's most prevalent in white non-Hispanics, followed by Black non-Hispanic, and then Hispanic population in pretty much all age groups. Now, this is a bit, complicated, I guess, a slide, but in general, it is showing the comorbid conditions. And ADHD is very rarely diagnosed as a monodiagnosis, right? It always, I mean, kids or adolescents or even adults with ADHD most commonly have some type of comorbid or coexistent conditions. And as you can see, the most common ones are other behavioral disorders like, a positional defiant disorder, conduct disorder, but it also is often, present along with anxiety, depression, and other conditions, including learning disorder, developmental disorder. Now, how do you diagnose ADHD, right? That's a kind of a big question and important question, because it's not uncommon when a parent comes to my office and says, "Hey, doctor, we had this, neuropsychological testing done at school, where, we paid, $5,000 and had it done privately, and they diagnosed my child with ADHD. So we're here to get, treatment, maybe medication treatment." And I always kind of explain to my patients and their families that testing, is extremely important. I think, having a thorough neuropsychological testing done is very helpful for diagnosing, ADHD. But ultimately, it is a clinical diagnosis, and a thorough history and clinical examination by a competent physician is the gold standard for diagnosing ADHD. Again, it's important to talk to families, parents, friends, co-workers, get some school records, report cards, results of any kind of testing, including neuropsychological testing, rating scales done by the parents and teachers. But by the end of the day, you are going to diagnose it as a clinician, not based on what the tests show. And the same applies for diagnosis of ADHD in adults. You have to look at the current symptoms, look at if the symptoms impact your, functionality, right? I mean, if somebody has, some, mild symptoms of ADHD, mostly, let's say, inattention, some distractibility, but, he or she, has been doing well, graduated from school, going to college, getting good grades, functioning well. I mean, do you really need to treat that, even if they meet criteria for ADHD? So you have to look at the impairment. Does this condition impact your functionality and quality of life, right? And you have to, again, even in adults, you have to make sure that you can trace back the onset of symptoms before the age of 12, right? I mean, some people, come to you and say, hey, you know what? I mean, all my teachers told me that I have some, difficulties with, staying focused, paying attention. I've been, fidgeting nonstop in class, couldn't, sit still. But my parents never believed in ADHD, never believed in treatment. So I never, got what I needed, and I didn't do well in school, didn't, do well in college, and I'm having a hard time finding a job, right? Um, so also have to make sure that you look at, again, comorbid conditions. I mean, sometimes you see a patient presenting with clear signs of depression and anxiety, but they, especially adolescents, they heard about ADHD, right? Many of their peers have ADHD, and they say, well, I can't focus. I probably ADHD. And you ask more questions and you realize it's not necessarily ADHD per se. It is really this cognitive dysfunction is really driven by depression and anxiety, which we do know these conditions can definitely impact your cognitive functionality. And again, it doesn't mean that depression and anxiety can't coexist with ADHD, but you probably need to treat those conditions first, make sure that uh, uh, um, you control for that particular, variable before you address the symptoms of ADHD. As I mentioned before, comorbidity is a rule rather than exception in kids or adults with ADHD. So in adults as well, I mean, psychological or neuropsychological tests are not required. You can diagnose somebody with ADHD without having formal testing done, although again, those are very helpful. It's also helpfMPFul to order neuropsych testing when you suspect any kind of neurodevelopmental disorder or learning disorder. And again, fMRI studies or lab tests are not required for diagnosis of ADHD. So there are some diagnostic instruments which we very commonly use, and these are very helpful actually in kids, especially we use with what's called Vanderbilt ADHD Diagnostic Rating Scale. It's available for parents and teachers, so you can get information both from parents and teachers, and it's always very helpful. This is a very kind of detailed instrument. You can see what exactly is going on at school or at home, how the teachers or parents see the symptoms in those environments. But there are many other instruments. Again, you can just Google those and see which one works the best for you. Most of those are free. In adults, we have this ADHD self-report scale. And again, it is important to get some collateral information from friends, families, workplace, and things like that. Now, here I try to show the kind of progression from a childhood to adulthood for someone with symptoms of ADHD. So in childhood, kids with ADHD often have school failures and underachievement. In adulthood, you have job failure and unemployment. In kids, we see them experimenting with drugs and alcohol, and if left untreated in adulthood, you deal with substance and alcohol use disorders. Kids engage in high risk and impulsive behaviors. And in adulthood, it ends up again in high risk behaviors and wanting pregnancy, motor vehicle accidents, although this happened obviously in adolescents as well, high schoolers. And then in kids, we see, as I mentioned already, comorbid oppositional defiant disorder, conduct disorder, which in adults translates into antisocial personality disorder and involvement in criminal justice system. In kids, that there are repetitive failures. In adults, it often develops into a kind of frustration, hopelessness, and giving up. So why is it important to treat ADHD? What happens if you don't treat ADHD? So we have educational underachievement, academic failures. Kids don't do well in school. They fail grades. They don't get into a college that they wanted to go to. They will often have kids ending up in low SES status because of their academic and and job, situation, a poor quality of life, low self-esteem, emotional and social impairments. Again, high-risk behaviors like motor vehicle accidents, DUI, substance and alcohol use, unwanted pregnancies, crime and delinquency, premature death and suicide. 50% of kids with untreated ADHD are more likely to get injured, and about 40% are more likely to be unemployed. So, okay, let's see, what do you do? How do you help these kids or adolescents or adults, right? So there are two main types of treatment, right? Psychotherapy and psychopharmacology. You can do therapy in a broad kind of meaning of that word, or you can use medications, right? Or you can do both. And psychostimulant medications represent the largest single class of psychotropic medications prescribed to children in the United States. And as I'll show, this is also the most efficacious treatment choice for symptoms of ADHD. Now, when you develop a treatment plan, you have to educate children, their parents about the ADHD, and talk about the individual's strengths and weaknesses. You have to use local and online resources for education and support. Again, there are lots of online resources like American Academy of Child and Adolescent Psychiatry has so-called facts for families where they provide information about the ADHD and many other psychiatric diagnoses. You have to help the families to implement homeschool lifestyle changes, quiet workspace for adults, maybe extra time for tests in kids, and in many cases, you have to guide these families to apply for 504 special ed plan or individualized education program at school or in college. I have to consider vocational assessment and career counseling, set reasonable expectations of pharmacological and psychosocial treatments. It is not uncommon that, again, parents come to and say, we have this, neuropsych testing, which clearly shows my child needs medications, and they expect the psychostimulants to fix everything, right? That doesn't happen that way. You have to really work with them and explain the importance of medication management, psychosocial treatment. And again, you have to help them in transitioning from middle school to high school to college, and when they find a job, you often have to provide letters to their school or employers about the history of treatment and what kind of accommodations they might need. Let's talk about psychopharmacology of ADHD. And there are three classes of medications that are FDA approved for treatment of ADHD. The first class is the class of psychostimulants, and there are two subclasses in psychostimulant medications. One is the class of methylphenidate, and the second one is the class of amphetamines or amphetamine salts. There's also a class of these medications that are, there are two medications called atomoxetine and viloxazine, and there are also a class of alpha agonists or antihypertensive medications like clonidine and guanfacine, right? And there's also off-label treatment for ADHD, which, we try to, of course, avoid, but in some cases, when you try all other, FDA-approved options and you still don't have much success, we might need to discuss possible use of off-label medications for treatment. Now, so for psychostimulants, there was a big study done published just recently in the Journal of American Medical Association. It's a cross-sectional study of close to like 11,000 or 12,000 kids 9 to 10 years of age. About 13% of children with parent-reported ADHD were currently receiving medications, including 15% of boys, about only 7% of girls, 14% of white children, and 9.4% of black children, and about 32% of kids of parents with a high school education, without a high school education, about 11% of children whose parents had a bachelor's degree. So this is a slide about the psychostimulant and other medications. As you can see, this is the methylphenidate group. There are lots of choices, and they keep developing newer drugs in this category of psychostimulants. That the medications that would have less side effects and last longer, right? And there is this medication called the brand name Journey PM, which you can actually give at night around 8 p.m. And when the child wakes up in the morning, the medication is already kind of working. So many kids who kind of younger kids who wake up in the morning already being extremely hypermobile, hyperactive. Sometimes we use this medication, but again, there are many other medications that you can try for treatment of ADHD. And this is the amphetamine formulations. As you can see, we have lots of choices here as well. And on the bottom of the slide of this picture, you can see the non-stimulant medications that we, as I mentioned, also use for a treatment of ADHD. Now, I would like to again briefly talk about the situation in Armenia. And as I mentioned, the psychostimulant medications are not available formally in Armenia. And again, I have to kind of make a disclosure here that I don't know exactly where this data where is coming from. This was shared with me by one of my colleagues from Armenia. And again, I don't know exactly how accurate these numbers are. But as you can see, in Armenia, the methylphenidate or amphetamine salts are used only 5% of kids. And I obviously can't say how they get these medications because, again, those are not formally approved or available in Armenia. But what's really concerning is that it looks like providers have to use medications like risperidone and aripiprazole, which are antipsychotics or mood stabilizers. They're FDA approved for treatment of bipolar illness, schizophrenia, and other disorders. And they are sedative medications, right? We use those for aggression, agitation, let's say in the inpatient hospital. And if you give it to a child with ADHD, it's not going to treat ADHD. It doesn't treat the symptoms of ADHD. It just is going to kind of sedate the patient, kind of calm the patient down, right? And that way you might achieve some, control over any kind of, aggressive or impulsive behaviors. But again, this is a highly inappropriate approach when you use antipsychotics or mood stabilizers for control of behavior of a child with ADHD without actually addressing the main issue, which is the diagnosis of ADHD. The main study that was done in 1999 is called Multimodal Treatment Study of Children with ADHD, or MTA study. This is kind of the gold standard study for use of psychostimulant medications in ADHD. And again, it's a pretty old study, but it still believed to be the kind of landmark study for proving the efficacy of a particular treatment option for ADHD. So this was the study that looked at kids ages 7 to 9, about 580 kids with diagnosis of ADHD. And these kids were randomized to treatment for 14 months, and there were 4 treatment arms. The first one was systematic medication procedures involving the initial titration to establish the optimal medication and dosage, followed by monthly pharmacotherapy visits. The second arm was intensive behavioral treatment package, including home, school, and summer treatment components. The third treatment arm was combination of psychostimulant medication with behavioral intervention, right? And the fourth arm was treatment as usual in community settings. So at 14 months, both the medication group and the combination group outperformed behavioral therapy alone or community-based treatment. The combined treatment was more useful in comorbid ADHD cases, let's say ADHD with anxiety, because as you can, I think it also makes sense, right? I mean, psychostimulants treat ADHD, they don't treat anxiety, they don't treat depression. And in behavioral therapy, although the primary target in this particular case might be ADHD symptoms, but it is still a therapeutic intervention, so I think they might be able to address some comorbidities as well, right? But the combined treatment also had more subjects in remission, and kids who received both psychostimulant medication and behavioral intervention apparently have been able to use a lower dose of methylphenidate. So these are the response rates. In combined group, about 68% response rate, which is pretty high. And the medication alone, the methylphenidate treatment alone also was very efficacious, about 56% response rate. Behavioral treatment by itself, I mean, still worked, but obviously the numbers are pretty low, and the community comparison was pretty low, 25%. Now, there was an 8-year follow-up for the same MTA study right after the 14 months of treatment, and there was little difference among initial treatment arms for ADHD outcome. So pretty much what that means is that kids responded well to treatment medication and therapy. They continued responding well to that treatment modality, and kids who were responding well to medications, they continued doing well on medication treatment. And the best response during the 14-month trial was equal to best response of the 8-year follow-up. Now, this is kind of important when we say kids, our adolescents improved, right? They did improve a lot. Obviously, they achieved significant remission in their symptoms, but they never reached the level of functioning of local normative comparison children, right? So kids who have never had ADHD still did better than kids who had ADHD and responded well to treatment. And about 30% of kids still continued meeting criteria for ADHD even after receiving all these treatments. Now, this is a kind of interesting, graphical representation of some of the response rates in the same MTA study, right? On the left top graph, you see the teacher's report on hyperactive impulsive symptoms. As you can see, both the combined treatment and medication treatment led to significant improvement in hyperactive and impulsive symptoms. On the left bottom graph, you can see that the total social skills also improved significantly, both in a combined treatment, which is medication with therapy, as well as with medication treatment alone. On the right side, you'll see the parents report, and you see that there has been improvement in internalizing symptoms with both combined group, but also with behavioral treatment, right? Because internalizing symptoms are those like anxiety, depression, things like that. So apparently therapy works pretty well in those situations, but the combination of medication with therapy still seem to be the best approach. And also parent-child arguing, right? I mean, unfortunately, it's a big issue. Kids with ADHD, they start doing things impulsively, hyperactive, don't, listen to the parents, lots of arguments at home, right? And as you can see, the combination of medication with therapy led to significant improvement in this variable of parent-child arguing. Now, youth with ADHD are more than 3 times as likely as typically developing peers to have low educational achievement, and more than twice as likely to drop out of school before age 16, and more than 8 times as likely to have a record of special educational needs. Now, this slide shows the academic outcomes with and without treatment, and on the left side is the achievement test. As you can see, the MMT stands for multimodal treatment. So again, it's a combination of medication with therapy. As you can see, that MMT group seems to do the best, both in regards to academic performance and achievement tests. and for the achievement tests, medication treatment and non-medication treatment seem to still do better than no treatment. But in academic performance, interestingly, non-pharmacological treatments seem to do a bit better than pharmacotherapy. There was a Cochrane review done of 34 studies back in 18 looking at the academic performance and use of methylphenidate, psychostimulant medication, right? So methylphenidate improved math productivity, math accuracy. It increased reading speed, but not reading accuracy. And none of the mediators or moderators tested affected methylphenidate efficacy. So these are very potent medications. If they work well and if the patient tolerates these medications well, they usually do seem to do their job pretty effectively. I'd like to also briefly touch base on this, so-called PADS study, which is preschool ADHD treatment study, which was NIMH funded study done again pretty a long time ago in 2007. This was a study for a very young age group, 3 to 5.5 years old kids. So they received parent training for 10 weeks, open label safety leading for 1 week, and double blind crossover titration for five weeks of methylphenidate starting from 1.25 up to 7.5 milligrams 3 times daily. And there was a double blind parallel phase for 4 weeks, and then open label maintenance for 10 months and placebo discontinuation for 6 weeks. In this slide, you can see that, so these are two ratings from both parents and teachers. And as you can see, there was significant improvement with treatment with medication, and the higher doses seem to have higher efficacy. Let's talk about, I think we kind of briefly mentioned about a high risk of substance use in adolescents and adults with untreated ADHD. Attention deficit hyperactivity disorder is associated with earlier initiation and higher rates of lifetime substance use. And as you can see the numbers here, the nicotine is about 40%, alcohol 30 to 40%, cocaine 10 to 30%, cannabis is about 50%, and opiates are also about close to 20%. And ADHD has been shown to be an independent risk factor for tobacco use, specifically in clinical and high-risk samples. Substance use in ADHD may be considered as a form of self-medication for patients with ADHD. And it's very common to kind of see, adolescents saying, what I mean, I smoke marijuana, it kind of slows me down. So it kind of helps with this hyperactivity or, hypermobility part, where it's over this kind of hyperness feeling, right? Given that some substances have been shown to reduce ADHD symptoms, abstinence may be more difficult for adults with ADHD. Now, it is crucial to really treat ADHD symptoms early. And there was a study done at Harvard showing that if individuals who initiated stimulant medication therapy for ADHD later and for shorter duration, and those who reported only non-stimulant medication therapy for ADHD had significantly greater odds of substance use in adolescents relative to individuals who initiated stimulant medication therapy earlier, before the age of 9, and continue taking medication for a longer period of time, for 6 or more years. So if you do see a child or adolescent, and if you do feel like the patient meets criteria for ADHD, and the patient agrees to get help, and the parents agree to get help, I do not believe there should be any reasons for you to hesitate to really treat the patient. And sooner you do it and longer you do it to maintain the stability, I think higher the chances that these kids or adolescents or adults will have low risk of engaging in high-risk behaviors, including substance use. So this is again a study published in JAMA, and you can see that kids or adolescents with symptoms of ADHD who received versus who didn't receive medication or stimulant medication for symptoms of ADHD had significantly different levels of substance use disorder. So kids who or patients who received treatment with psychostimulants had significantly low rate of substance use disorder, and the same applies to smoking dependence. Treatment with psychostimulant medications does reduce the rate of smoking in adolescents. So this is another slide from pretty recent study showing increased prescribing of ADHD medications and real world outcomes over times. As you can see, in all of those variables like self-harm, unintentional injury, traffic crashes, and crime rates, treatment with medications clearly seems to improve those outcomes. Now, treatment with ADHD, as I mentioned previously, helps with obviously symptoms of ADHD, but it also does seem to improve symptoms of comorbid conditions. As you can see that here, there was a study of about 140 boys with 10-year follow-up data. This is again a Harvard group. So those who received treatment with stimulant medications noticed significant improvement in symptoms of depression and anxiety. And the same applies for oppositional defiant disorder and repeated grades. If you remember, I mentioned that ADHD, although it sometimes for many people doesn't sound like it's a serious condition, right? It is a very biological condition, right? And there have been lots of neuroimaging studies done, and this particular study looked at what happens to the brains of a youth with ADHD if they receive versus do not receive treatment. And as you can see from the right column here, kids who receive stimulants, this is the blue line, and the green line is the normative date, right? Kids with no diagnosis of ADHD receiving treatment with medications for ADHD seems to bring those kids significantly closer to the normative, comparison group. But again, if you remember, I also mentioned that they do not seem to achieve full level of functionality of their peers who have never had a diagnosis of ADHD. But as you can see, kids or adolescents who do not receive treatment, they do have significant impairment in their brain development. Now, based on what we discussed so far, it looks like psychostimulant medications are effective, and they are very effective medications, and they do treat ADHD symptoms pretty well. And again, we have many choices from different types of psychostimulants to consider. But there are also some side effects that we often observe with these medications. And the most common side effects are decreased appetite, insomnia, headaches, stomach aches, irritability. But it's also important to kind of reassess for those symptoms before you start the treatment, because some kids, they just don't sleep well, right? Or some adolescents, and they don't eat well, and you start the medication, they start complaining of those symptoms, but it's hard to really understand how much worse the symptoms are, or are those actually side effects of the medication, or they're the baseline symptoms that the patient had before they started the treatment. There is also impact of psychostimulant medications or weight and height, right? Children who received intensive medication treatment for 7 days a week grew about 4.25 centimeters on average and gained about 1.6 kilos on average. Children who received just behavioral therapy with no medications grew at 6.1 or 2 centimeters on average and gained 4.53 kilograms on average. So as you can see, there is significant impact of psychostimulant medications on weight and height. But again, those side effects reverse once you stop the medication, and that's why many patients with ADHD take either like the weekend holidays. Let's say they take the medication during the school week, and they take no medications during the weekend. Some people stop taking the medications during the summer. But again, many kids or adolescents or adults, they do take this medication every single day, because when they stop using those medications, they clearly see a big difference in their symptoms and their functionality and their quality of life. So this is kind of a graphical presentation of the side effects on weight and of the stimulants on weight and height. As you can see, those who took these medications consistently on the right side of this slide, they had significant decrease in both weight and height. Now, in 2011, there was a study published that showed that ADHD medications can cause serious cardiovascular events in children and young adults. There was a retrospective cohort study of about 1.2 million children, young adults between the ages of 2 and 24. And the study identified serious cardiovascular events, including sudden cardiac death, acute MI, and even stroke from based on health plan data and vital records. So based on the study results, about 80, the core members had 81 serious cardiovascular events, which is 3.1 per 100,000 person years. And current users of ADHD medications were not at increased risk for serious cardiovascular events, and risk was not increased for current users as compared with former users. And alternative analysis addressing several study assumptions also showed no significant association between the use of ADHD medications and risk of a study endpoint. American Academy of Pediatrics and American Heart Association came up with guidelines on cardiovascular monitoring before starting stimulants for ADHD. So the recommendations were to carefully assess children being considered for ADHD treatment by using a targeted cardiac history, like patient history of cardiac diseases, palpitations, syncopal episodes, seizures, any family history of sudden cardiac deaths, or hypertrophic cardiomyopathy or long QT syndrome, as well as, of course, physical examination, including cardiac examination or EKG. And there was another study just came out just recently. This was done, I think it was a Sweden or Norway study, and they looked at about 278,000 individuals with ADHD, and again, they said that the results showed that long-term exposure to ADHD medication was associated with an increased risk of cardiovascular diseases, especially hypertension and arterial disease. And across the 14-year follow-up, each 1-year increase of ADHD medication was associated with a 4% increased risk of cardiovascular disease, with a larger increase in risk in the first 3 years and a stable risk over the remaining follow-up. So again, long-term use of ADHD medications compared with no use is associated with increased risk of hypertension, arterial disease, but no statistically significant increased risk for arrhythmias, heart failures, ischemic heart disease, thromboembolic conditions, or cerebrovascular disease. So, in general, it's important to really talk to your patients about these studies, about the data and about the risk of possible cardiovascular diseases. or side effects. And I always tell my patients, especially younger patients, if you're taking medication for ADHD and you're, playing sports, especially during the summer, make sure you stay hydrated. Make sure they check their blood pressure and pulse rate pretty regularly. And this is the form from Mass General Hospital. I always provide it to all of my patients to fill out. And if there are any, positive findings here, I always refer my patients to see their pediatricians or, primary care providers to maybe have a baseline EKG done before prescribing psychostimulant medications. But again, you got to be careful and not to kind of over uh, represent the data that's available, right? I mean, it's important to be careful, but you should make sure that you uh, weigh the benefits of treatment with ADHD and comorbid conditions and other risk factors that we just discussed about, like including substance use versus the side effects, right? And I think it's a very kind of fine balance, but you got to make sure you have both variables looked into and make your clinical decision. But in this form, I think it's available for free. I think it's always a good idea to provide this to the patients and their families at the intake. There have been some studies showing that kids with motor tics or Tourette syndrome get worse on psychostimulant medications, right? But there are also been some studies showing that, in fact, kids who have ADHD and comorbid Tourette syndrome or tic disorder, they actually improve on ADHD medications, especially psychostimulants. So I've always been kind of struggling in the field of child psychiatry what to do with kids, who have both of those conditions. And there was a meta-analysis of 22 studies done in 2015. And the new onset tics or worsening of tic symptoms in psychostimulant group and placebo groups are shown here. And so the risk of new onset or worsening of tics associated with psychostimulant treatment was similar to that observed with placebo. So in general, I guess the consensus is that psychostimulant medications do not make tics worse. So if you feel like you have a patient who clearly is in need for treatment for symptoms of ADHD, and as we discussed, psychostimulants are the most effective treatment for ADHD. And if that patient has tic disorder or Tourette syndrome, that should not prevent you from at least giving a trial for a psychostimulant medication. Again, if the symptoms of tic disorder or Tourette syndrome get worse, you can certainly discontinue the psychostimulant medication and try an alternative, treatment modality. So we kind of talked about mostly psychostimulants, and again, those are very effective medications, and the data show that. I mean, those of you who prescribe those, you probably know that it changes things. I mean, it's not uncommon for patients to start the medication and actually even like the next day, the parents they say, my child went to school and the teacher calls me and says, hey, I mean, what's changed? I mean, this is not the same a student I had. I mean, he has been kind of, or she has been sitting still and listening and things like that. So the parents say, oh, this is kind of a really big change. So again, there are very effective medications. They're scheduled to control substances, right? So you got to be very careful when you prescribe medication. You should not overprescribe medication, and you should always check the PDMP or cure system, which I'm pretty sure you're familiar with, before you order a new medication. You should make sure that you check when was the last time they filled the prescription. Make sure that they don't get it from somebody else as well, another provider, right? And make sure you give only 30-day prescription. As you know, these medications are not refillable. You can't give refills. You have to order it every 30 days. I mean, ideally, you should be seeing your patients every 30 days, but especially with our busy practices, especially in the field of child adolescent psychiatrist, where there are not too many board certified pediatric psychiatrists, in the country, we don't have that luxury of seeing our patients every month. And you could maybe prescribe 2 or 3 in months of this medication, like with the do not feel until kind of, note in the prescription. But again, ideally, you should be seeing them as frequently as possible. I would certainly not recommend to give any prescriptions for more than 3 months for psychostimulants. But let's talk about non-stimulant medications, right? So there's this medication called atomoxetine, which interestingly, originally it was developed as an antidepressant medication. The trials were for antidepressant effect of this medication, but it failed antidepressant trial, and I guess they looked at some other effects of this medication, and they did more studies for ADHD, and atomoxetine did get the approval for treatment of attention deficit hyperactivity disorder in youth. So we often use this medication for uncomplicated ADHD for kids or adolescents or adults who are not responding well to treatment stimulants, or who have comorbid conditions like anxiety or depression, tic disorder, disruptive behavioral disorders, or substance use disorders. And again, as I mentioned, this was developed as an antidepressant, although it failed the trial, it doesn't mean that it didn't work at all, right? It didn't beat the placebo. So, but it still does have some effect on symptoms of anxiety and maybe depression, although again, you got to be very careful when you obtain consent and make sure you don't, say that we're going to also treat your depression with atomoxetine, because you're not. So atomoxetine is also commonly used in adolescents with ADHD and comorbid substance use disorder. There was a study done in 2010 looking at about 70 adolescents, 13 to 19 years of age, with DSM-4 diagnosis of ADHD and at least one non-tobacco related substance use disorder. They were randomized to 12 weeks of atomoxetine plus CBT. And therapeutic interventions. The main outcome measure was ADHD self-reported checklist score. And for substance use disorder, the main outcome was self-report number of days used non-tobacco substances in the past 28 days using the timeline follow back interview. And yeah, sorry for the quality of this slide. But as you can see, by the week 12, there was a statistically significant improvement in therapy, or not motivational interviewing, and with atomoxetine versus a placebo and motivational interviewing group. So I think this is also a slide about efficacy of atomoxetine for ADHD with comorbid anxiety versus placebo. As you can see, there was a statistically significant improvement in ADHD symptoms and anxiety symptoms in patients with treatment with atomoxetine. Let's talk about the third class of medications that is also FDA approved for symptoms of ADHD. It's a class of alpha agonists, and the two main medications here are guanfacine and clonidine. We often use those medications sometimes as monotherapy, right? Many parents, they have to provide psychoeducation about the options for treatment of ADHD. They feel uncomfortable about using stimulants. They don't want to use this Schedule II controlled substances for their kids, especially younger kids, right? And they ask about other options. And again, alpha agonists are some of those medications that we can use as monotherapy. We also use those in patients who did not respond well to treatment, either stimulants or let's say atomoxetine, right? Or who are partial responders, or those who tried stimulants or no stimulants and developed some side effects. We also often use these medications in patients with ADHD and comorbid a positional defiant disorder, tic disorder, some emotional dysregulations, and anxiety. And also in younger kids, we often use this medication. In fact, in the inpatient, I provide inpatient psychiatric care as well, both to children and adolescents at January Behavioral Health in Concord, California. And we often use these medications for younger kids with this kind of behavioral, presentation, right? They're hypermobile, hyperactive, impulsive, all over the place, right? And the alpha agonists do seem to improve that behavioral component of ADHD. Now, they don't seem to do such a great job with the cognitive part, right? If you are trying to target like cognitive functioning of patients with ADHD, like attention, focusing, memory, things like that. I don't believe alpha agonists as a monotherapy are very effective from that perspective. I think psychostimulants seem to do a better job. But there was also a study done by Tim Williams from Mass General in 2010 looking at the combination treatment of psychostimulants with alpha agonists. And as you can see, the combined treatment does seem to outperform treatment with psychostimulants and placebo. And we do, in fact, use this very commonly. I think using psychostimulants with alpha agonists together also helps us to use a bit lower doses of both medications versus just using a high dose of psychostimulant medication only or alpha agonist medication only. Now, there are also non-medication interventions, right? So we talked about most medications. Again, the main classes are psychostimulants, which include methylphenidate and amphetamine class. There are medications like atomoxetine, which are also commonly used in kids with and adults with ADHD and comorbid conditions. And there are also medications like clonidine and guanfacine, which are alpha agonists. And again, have to kind of, consider what's the best option for your patient based on their preference, based on the side effect profile of the medication, and based on thorough review of past medical and psychiatric history. But again, you can also do a therapy, right? And I think we looked into therapeutic interventions, including behavioral therapy in the MTA study. And therapy is extremely important, of course, right? There are many types of therapy. There's what's called cognitive behavioral therapy or CBT. There's mindfulness-based interventions. There are parent training in behavior management, behavioral classroom interventions. I think we talked about the school interventions, which includes like 504 plan or individualized education program. There is organizational skill training. There's also neurofeedback and biofeedback. And of course, physical activity and lifestyle approaches are extremely important. I think whenever you have any patient with ADHD, doesn't matter if it's a child or adult, you have to really make sure that you emphasize the importance of maintaining a good sleep routine, good sleep hygiene. Nutrition is extremely important, right? We talked about side effects of stimulants, and suppression of appetite is one of the main side effects. And very commonly, patients say, you know what, it's not like that I'm not hungry, I forget to eat. I don't have that feeling that I'm hungry. So because of that, I just forget that I need to eat. So I kind of tell them, put an apple right in front of next to your desktop or whatever you are doing, right? So you can at least remind yourself that, that I need to eat something. And exercise. I mean, they have to really exercise, because I think there's growing evidence that physical exercise does improve mental health in general, including symptoms of ADHD. So for psychotherapy specifically, there was a study done, a Cochrane review done in 2018. The study objective was to assess the effects of CBT or cognitive behavioral therapy for ADHD in adults. They looked at 14 randomized controlled trials. And the conclusion was that there is low quality evidence that CBT-based treatment may be beneficial for treating adults with ADHD in the short term, and reduction in core symptoms of ADHD in CBT plus pharmacotherapy group was more noticeable. I think this kind of goes along with the results of the MTA study, if you remember the adolescent study for treatment of ADHD symptoms, which also showed that combination of methylphenidate psychostimulant medication with behavioral intervention seems to outperform or all other three arms of treatment. So this is a statement from the American Academy of Pediatrics. The AAP notes that while behavioral therapies may not have as strong and immediate effect on core ADHD symptoms as stimulant medications, they address broader functional impairment, and their positive effects tend to persist beyond the treatment period. So just in general, I think therapy for any child or adolescent or adult who has any kind of mental health or psychiatric diagnosis, I think is really important. Medications, they have their place in treatment. They might help a lot. They might be an important part of the treatment, especially with ADHD, based on the data I presented. But again, therapy also helps. I always tell my patients and their parents, the medication is a passive treatment, right? It improves the symptoms. It helps you to be more focused, pay better attention, be more organized, to feel better, to feel less depressed, less anxious. If let's say we're talking about antidepressants, but it doesn't teach you how to do better, right? I mean, you need therapy, you need to talk to somebody to kind of understand what's going on, why they feel this way, and how to improve things, how to modify, your behavior, your thinking, your mindset, right? So that's why I think therapy is always important, including if you're treating somebody with ADHD. Family therapy might also be extremely important because, as you can imagine, it's not just kids or adolescents with ADHD who suffer, but their families go through a lot as well. And there also, as you can imagine, nowadays there are lots of vitamins and supplements and some other types of I don't know, compounds that people use, and many of those things get advertised as this magical treatment for ADHD. Unfortunately, there is no magical treatment for ADHD or any other psychiatric conditions. So you got to be very careful about what you recommend to your patients about use of vitamins or supplements. And there are not, too many studies to show if any of the supplements can be effective, right? I guess one of the compounds that has been researched probably the most is omega-3 fatty acids, and there have been a few studies looking at the efficacy of omega-3 for treatment of ADHD. There was a 3 month or a randomized control trial of 75 kids with ADHD, and there was no significant difference in omega-3 fatty acids versus placebo for ADHD symptoms. But there was some improvement, I guess, in clinical global impression scale. There were some other studies that showed some improvement, but a recent Cochrane review from I think it was 2023 showed that omega-3 fatty acids there was limited evidence of benefits of omega-3 fatty acids for treatment of core symptoms of ADHD. So I didn't talk about many other treatment interventions. Let's say, I mean, I know that especially overseas, even in Armenia, there have been some talks about use of neurofeedback. And again, I think it's really hard to say anything conclusive about those interventions, because I think most of the recommendations about those interventions come from really anecdotal data. I don't think there are any strong controlled trials to show efficacy of those interventions. I think what I showed you in this presentation is based on what we know scientifically about what works for ADHD in kids or adults. In conclusion, attention deficit hyperactivity disorder is highly heritable, chronic neurodevelopmental disorder persisting into adulthood with significant functional impact. Early diagnosis and comprehensive assessment are essential. Comorbidities are the rule rather than the exception in patients with ADHD. Untreated ADHD is linked to academic underachievement, substance use, high-risk behaviors, and reduced quality of life. Multimodal treatments, which includes combination of pharmacological and non-pharmacological or psychosocial interventions, offer the best outcomes, especially for patients with comorbid psychiatric conditions. Psychostimulants do remain the first-line treatment. So if you have a classical patient, or patient with classical symptoms of ADHD, and there are no reasons not to prescribe psychostimulant medications, and you want to provide the best care, you should probably consider using psychostimulant medication after obtaining consent from the patient or guardians as necessary. But again, behavioral and lifestyle interventions are extremely important, and they address broader functional impairments, and long-term monitoring is crucial to manage side effects, comorbidities, and transitions across the lifespan. And public health gaps remain, particularly in countries with limited access to evidence-based ADHD medications, which we kind of talked about, is the case with Armenia. So there are a few questions I can go over briefly, and I think the slides are going to be available for your review anyways. But the question number one is, according to the preschool ADHD treatment study, or PATS, which we discussed, when preschoolers with ADHD were followed up to 3 and 6 years, they were most likely to be on which of the following medication regimen? Number one is alpha agonist monotherapy. Number two is antidepressant plus a stimulant medication. Number three is antipsychotic plus stimulant medication. Number four is stimulant monotherapy. And the correct answer is D. And again, it's stimulants. If you remember, we showed the methylphenidate response in young kids. Question number two, what symptom is prevalent in ADHD throughout the lifespan and is a major contributor to impairment? Agitated depression, emotional dysregulation, hostility, hypomania. So the correct answer is B, which is emotional dysregulation. I think we probably didn't talk too much about comorbidities between like bipolar illness and ADHD. But again, that wasn't the primary objective of this presentation. But kids with ADHD do often present with emotional dysregulations. And in fact, some patients with ADHD also have comorbid bipolar disorder or vice versa. And in fact, it's sometimes very difficult to treat youth with bipolar disorder and ADHD because psychostimulant medications often cause, more mood swings, and sometimes there have been even some cases when there's a belief that they can trigger actual symptoms of mania or hypomania. So when we treat youth with bipolar illness and ADHD, we usually recommend to stabilize mood disorder first, and then use psychostimulant medications if necessary, or maybe even potentially use non-stimulant medications as a first choice. The prevalence of substance use was the highest among youth with attention deficit hyperactivity disorder who received treatment with a stimulant medication for 2 years or less, starting at the age of 10 to 14, 2 years or less starting at the age of 15 or older, 6 years or more starting at the age of 9 or younger, and 6 years or more starting at the age of 10 to 14. This is a bit complicated, but I guess the numbers, but if you remember, in one of the slides I showed, I specifically mentioned that based on the studies done at Harvard, it's important to start the treatment as early as possible and for as long as necessary, right? So the correct answer is B, which is 2 years or less, starting at the age of 15 years old or older. So this is the opposite, right? The substance use is going to be hard because you don't really treat soon enough and long enough. So thank you, and this is my contact information, my email address and website, and there's some information on my website as well about ADHD. If you have any questions or anything I wanted to discuss with me, please let me know. And we're also going to meet at the AMS meeting in Las Vegas in September, where I'll be presenting a shorter version of this presentation. Thank you.